Dyspepsia, a case study and evidence-based practice, presented by Anita Somalrayo, William Patterson University. Chief complaint: I have a burning sensation in my throat and indigestion which occurs more when I lie down. I can feel acid come up my throat and it burns. So this is a case study of a 58-year-old male who has recently started experiencing fullness after eating, heartburn, pain, and occasional acid reflux. In this case study, we will explore clinical features, diagnosis, symptoms, and severity, and how learn to differentiate from upper GI diseases. History of present illness. A 58-year-old man presents to office with complaints of burning sensation, pain, postprandial fullness, which occurs more than when he lies down. Patient can feel acid come up his throat occasionally. He's worried. The patient is mildly obese with no past medical history. His symptoms have been going on for past 1 year. He takes antacid and it gets better. Patient complains of discomfort in the throat and the chest, and for that he has taken omeprazole over the counter and it has helped. But now he wants to get it checked out on the suggestion of his wife. The patient also has to put on, he has also put on 10 pounds in last 1 year. Past medical history. He has not been diagnosed with any medical issues. He only takes vitamins. Surgical history. Patient has never been hospitalized or had any other surgery. Family history. Both parents are living, and the patient's father has high cholesterol and hypertension. The patient's mother has hypothyroidism and osteoporosis. The patient has a younger brother and is healthy. Sister is married with 3 kids and has high cholesterol. Social history. Patient is married with 2 kids who are healthy teenagers and are in school. He has his own business. He lives with his wife and two daughters in a single-story house. He was a heavy smoker but stopped 15 years ago, started again but smokes occasionally. He denies any recreational use. He is an occasional drinker. He and his wife eat healthy and go to the gym regularly. Allergies. He does not have any allergies, no known drug allergies, food allergies, or environmental allergies. Medications. He does not take any medication except for occasional antacid, and he took omeprazole once. Labs, they are unremarkable. CBC is within normal. Health maintenance. The patient took only one shot of COVID vaccinations. Date is 6/20/2020. He has not had any flu, pneumococcal, or shingles vaccine. He does not want them. Um, Last complete physical was more than 1 year ago, February 11th, 2023, and it was unremarkable. Subjective data. Review of the systems. General constitutional pain, patient denies fever, chills, malaise. Head, there's denies trauma, headaches, or pressure. Neck, there's no stiffness or tenderness. Neck is supple. EENT is within normal. Patient wears reading glasses, Perla. Cardiovascular, patient denies shortness of breath, chest pain, palpitations, respiratory. Um, he denies cough, asthma, dyspnea, chest is symmetrical, integumentary, skin is intact. GI, patient has heartburn, denies abdominal pain, nausea, and vomiting. But it is only occasionally, but denies right now. Denies increased appetite. GU, no changes in bowel or bladder. Objective physical exam. General, the patient is well nourished and obese and has no apparent distress. The patient is alert, awake, oriented. Neuro, he feels dizziness when he bends down. HEENT, head is no abnormality noted. Ears are within normal, eyes are within normal, lungs clear on auscultation, cardiac regular rate and rhythm, S1, S2, no murmurs. GI, patient has acid reflux, burning sensation, and is in throat and esophagus. GU, no issues. Vital signs is blood pressure 122/80, heart rate is 77, respirations are 18 breaths per minute, temperature is 98.7, oxygen saturation is 98, and BMI is 28.7. Assessment. Impression with ICD-10 codes. Working diagnosis: dyspepsia, ICD-10 K30. Definition: dyspepsia is another term that people have used for indigestion. It is a general term and refers to symptoms that are in upper GI tract. They are vague but in variety of symptoms like epigastric pain, heartburn, nausea, vomiting, abdominal distension, belching, early satiety, and anorexia. Acid reflux has been associated with this as well. Rome 4 criteria is more specific and has helped in research and better defining functional dyspepsia. The diagnostic criteria are the presence of at least one of the following: postprandial fullness at least 3 days per week, early satiety 3 days per week, epigastric pain 1 day per week, epigastric burning 1 day per week. And it should not have any structural or organic underlying disease. This has to be present for at least a month, and symptoms have to exist 6 months before being diagnosed. Dyspepsia types. There are two kinds: organic dyspepsia. The patient has an underlying pathological process that causes symptoms of organic dyspepsia and is diagnosed with clinical evaluation and lab tests, and they require endoscopy and radiological studies. To treat OD, you treat the underlying cause has to be treated. The organic dyspepsia is caused by a number of things, including GERD, peptic ulcer, gastroesophageal cancer, pancreatic biliary disorders, intolerance of food and drugs, and other systemic infections. Functional dyspepsia. This is most common dyspepsia and does not have any organic or underlying cause. It does not require endoscopy, radiological investigation, or any other imaging studies to be diagnosed, but it does require being tested for Helicobacter pylori and careful study of symptoms to be diagnosed. The patient has to have one of the following symptoms: epigastric pain, epigastric burning sensation, postprandial fullness, and feeling too full quickly after eating. This is a logarithm for diagnosis and treatment of functional dyspepsia, and to the right is room for diagnostic criteria for functional dyspepsia, plus it has two types of functional dyspepsia listed here: postprandial distress syndrome and epigastric pain syndrome. So these are the two kinds of functional dyspepsia. Differential diagnosis. Due to vague and generalized symptoms of dyspepsia, a simple can be confused with more serious problems or diseases like peptic ulcer, GERD, gastritis, irritable bowel syndrome, and gastroparesis. The main thing that we should remember when we are doing differential diagnosis is that this happens in the upper abdominal quadrant, so it's up near the chest, and it causes bloating, it causes nausea, acid reflux too, being full really fast, and it occurs like right after eating. So the first one is GERD. GERD can easily be mistaken for functional dyspepsia. GERD is primarily due to abdominal acid level that come up in esophagus, and they cause heartburn and regurgitation. GERD is associated with esophagitis, esophageal strictures, Barrett's esophagus, esophageal adenocarcinoma, and obesity. The testing for GERD is endoscopy, and they can also do stomach acid testing. Heartburn is very common in GERD. Severe heartburn along with the regurgitation of the food due to incompetent esogastric junction. Um, GERD can persist as erosive and non-erosive reflux disease. Erosive causes severe esophagitis. Second is peptic ulcer disease. As the name suggests, it is like sore in the digestive tract, mostly due to acid production. There are two kinds, gastric and duodenal ulcers. Most of the time there are no symptoms, but if there are, there's nausea, vomiting, bloated feeling, being full, abdominal pain near the belly button and breastbone. Most of the ulcers are caused due to H. pylori or eating too many NSAIDs. The main difference with dyspepsia is recurring indigestion in dyspepsia, and there are no sores or ulcers involved. While peptic ulcers can have tarry stools, fatigue, shortness of breath, weakness, and these are not present in dyspepsia. Pain in dyspepsia is on the upper abdominal area closer to the chest, not like the belly button in peptic ulcer disease. IBS. Irritable bowel syndrome, IBS, is functional dyspepsia. They both are very similar. IBS is also called the nervous stomach, and it might have vague symptoms like dyspepsia, but it is usually affected in bowels and colon. Um, Whereas the functional disorder appears more in the stomach and upper area. In IBS, there is the pain is more like cramping pain, and it is in the colon area, and it is either due to constipation or diarrhea. The main thing when diagnosing and deciding how to treat dyspepsia is watching out for the red flags. They indicate a serious problem and require urgent investigation. These red flags are difficulty swallowing, hoarseness in voice, recurring or persistent cough, unintentional weight loss, persistent vomiting, um, IDA, abnormal mass, and GI bleeding. Here are some to the right. I have put a picture of some more differential diagnosis of dyspepsia. Now, evidence-based plan. This is based on the clinical guidelines. This is for the patient that we are doing the case history on. The patient is in good condition, mildly obese. He has negative family history of malignancy. He tries to eat healthy, and he is an occasional drinker and a smoker. So pharmacologically, we will give him pantoprazole 40 milligrams in the morning when he wakes up, half an hour to 1 hour before breakfast, and in 1 month he can take occasional antacids. Um, Non-pharmacological is diet and exercise modification. um, it's important to refer him to stop smoking. So, smoking cessation counseling is important. To stop drinking, or at least he can switch alcohols or drinks to see which cause least amount of dyspepsia, like switching from wine to beer. He could also suggest weight loss, avoid fatty food, spicy food, eat small meals, and eat 2 to 3 hours before going to bed. There has been a research that they say that the foods that are high in fat, wheat, fermentable saccharides, caffeine increase the symptoms of dyspepsia. Follow up. The follow up has to be between 4 to 6 weeks, and further testing should be done if the symptoms are not relieved. In the next visit, intensity of abdominal pain, weight loss frequency, and regularity of the stools. Blood tests should be done. Further testing of H. pylori, occult blood, and ultrasound of the abdomen would be the next step. If H. pylori comes back positive, then he should be treated with antibiotics for 14 days. And the last step should be referral to gastroenterologist for EGD and colonoscopy. This is another management for uninvestigated dyspepsia to the left. And on the right is the lab test for the patient, what we are going to suggest. Um, we are suggesting X-ray and carotid Doppler for cervical spine, because when he bends down, he feels pressure. So we want to rule out any um, thing happening neurologically. For dyspepsia, we should refer him to gastroenterologist for colonoscopy, endoscopy, CT of the abdomen, pelvis, contrast, EKG to rule out cardiac issues, um, and uh, ultrasound, like we said, X-ray of the abdomen. Evidence-based plan, clinical guidelines. These have been suggested, um, and these are for functional dyspepsia. Functional dyspepsia accounts for 70% of dyspepsia in diagnosis is of exclusion. So we have to rule out serious diseases like malignancy and other H. pylori and other red flags. Um, Cause of FD when stomach is due to stomach motility, stomach emptying is affected, gastroparesis. Allergies can cause inflammatory response in the gut. H. pylori, a bacterial infection, causes inflammation as well. It can erode the mucosal lining, giving us similar symptoms of dyspepsia. The pharmacological are two. Approaches, the main ones are first neutralizing the acid-taking Maalox and Tums. The second is suppression by using PPI and histamine 2 receptors. Histamine 2 receptors, they block the histamine, which stimulates the parietal cells, and they can be taken like they're like famotidine. They can be taken for, the PPIs can be taken for up to 8 weeks. They should not be taken for longer than 12 months. Also, PPI like pantoprazole are the first line of treatment in dyspepsia. Diet and exercise. In some cases, people drink a lot of milk, alcohol, caffeine, fatty foods, fried foods, tomatoes, citrus foods, they give them dyspepsia. It is also important to eat smaller and more frequent meals to help with gut mobility. Important to avoid lying down for 2 hours, so there's no regurgitation. Overweight people can have dyspepsia, so people should lose weight. These are the questions, which I'll be posting separately, and references. And thank you very much for listening to my presentation.